Hi everyone, and welcome to this episode of Cardio Buzz. And today we'll be discussing a peculiar topic, which is contrast nephropathy. And if you're a radiologist, a nephrologist, a cardiologist, you will know how intimidating contrast nephropathy is to physicians and to patients. Our patients, when they hear that there's just a chance of injury to the kidney by contrast, then they usually refrain from going for the procedure. But it seems there is a breakthrough intervention that can positively impact contrast nephropathy and reduce its incidence.
Welcome to Cardio Buzz, your one-stop shop for all things cardiology. We bring the latest news and research on heart health.
There's no one better to talk on that breakthrough than Dr. Daniel Jones, who recently published on this breakthrough innovation in contrast nephropathy, and he's here with us in this episode. Dr. Daniel is an honorary consultant in interventional cardiology in Bart's Heart Center. He's a clinical senior lecturer of clinical trials in cardiovascular interventions in Bart's. He got 6 international awards in cardiology from the University of London, European Society of Cardiology, and the British Medical Journal. Welcome to Cardio Buzz, Dr. Jones.
Evening. It's a pleasure to be here.
You published about inorganic nitrates and that they could prevent a big proportion of contrast injuries. So tell us more about inorganic nitrates.
Yeah, as cardiologists, we're all very familiar with organic nitrates. So isosorbide mononitrate, GTN, dinitrates. However, I think it's important to be clear that inorganic nitrates are distinct from these medicinally synthesized drugs. Now, inorganic nitrates are found in the diet, particularly green leafy vegetables, and they're also endogenously produced in blood and tissues and represent a stable intravascular storage form of nitric oxide. And we know that nitric oxide exerts multiple beneficial effects, being antithrombotic, anti-inflammatory, promotes vasodilatation, and cytoprotective. And unlike the organic nitrates, such as isosorbide, you don't see the issues of tolerance or dependence that you get with you don't get them with the inorganic that you do with organic. And often things like organic nitrates can increase reactive oxygen species generation, which is something that would be harmful, whereas the inorganic nitrates can protect against it. So it's important to be clear that these are distinct, dietary, found endogenously, and different from the organic nitrates that we're probably all a bit more accustomed to as cardiologists.
Okay, so tell us more about the trial. Why did you think of inorganic nitrates with contrast nephropathy? What's the link?
Well, I think we've moved away from believing that contrast-induced nephropathy, is just that. So I think we've moved away from SIN as a terminology, and now I think we're all clear it's contrast-associated acute kidney injury, which has multiple mechanisms, including renal hemodynamic changes, oxygen-free radical formation, inflammation, embolization of material from catheters. And we know from previous study that we've conducted as a group with Professor Rawali at Queen Mary University of London that nitrite is endogenously converted into nitric oxide or reduced to nitric oxide. And that has multiple beneficial effects, which would be preventative in any organ, IR, or ischemia reperfusion injury. And we've tested it previously in a model of myocardial infarction, both preclinically and clinically, showing that there is evidence of a reduction in infarct size in primary PCI. And there's very similar mechanisms, as I've described, that would cause or precipitate contrast-associated kidney injury. And therefore, it made logical, pathophysiological sense to us that nitrate via its conversion to nitrites and then nitric oxide would potentially prevent contrast-associated kidney injury.
Okay, so I'll put the link to the study in the description of the episode. This is a study that included acute coronary syndromes, and a big proportion of them took a big volume of contrast. So some of them even took more than 300. So would you tell us more about the design of the study and what went in the study?
Yeah, so our hope was to pick a patient population we know that are at risk of contrast-associated acute kidney injury. So patients who are presenting with acute coronary syndromes and then undergoing coronary angiography are at high risk than a stable patient group for kidney damage. And therefore, we wanted to study this specific patient group. So patients with NSTEMI who have been stabilized for a period of time. So not primary PCI and not elective patients, but stable acute coronary syndrome patients. And the trial was a double-blind, randomized, placebo-controlled study where we randomized 640 NSTEMI patients to either inorganic nitrates in the form of potassium nitrate or potassium chloride. This was delivered at least 2 hours prior to the angiographic procedure. That's the first dose. And then it was administered for 5 days after the procedure, with the primary endpoint being the incidence of contrast-induced nephropathy as measured by the KDIGO criteria at 3 days, or 48 to 72 hours. And I guess from the question specifically about contrast and patients, we wanted to try and pick patients who we would believe to be at risk of contrast nephropathy, in addition to just presenting with an NSTEMI. So ideally, patients, we were aiming for a moderate to high MERON risk group, which we achieved, which I guess when we talk about the results with the median MERON score of 10 in both groups, which fits us in the range that we were hoping for. And that meant that we were trying to aim for patients who are elderly, who are diabetic. And we selected the risk based upon our own hospital's need or recommendation for contrast-induced nephropathy prophylaxis, which were things like age, diabetes, use of nephrotoxic drugs.
Good. So what was the intervention exactly? It was 2 tablets given before angiography?
Yes. So it was a 5-day course of either potassium nitrate or placebo. It was 12 millimole of potassium nitrate or the matched placebo. They were indistinguishable. So both the operator and the patient were blinded to the allocation, and you couldn't tell the difference. The dose is quite a high dose of nitrates, and therefore we had to split it into 2 pills. It was too big for 1 pill, hence the 2 pills given for the 5 days. And that was obviously in addition to standard measures to prevent contrast-induced nephropathy at our institution, which is routinely to give prehydration with IV fluids both before and during the procedure.
That's great. And what was the effect of the inorganic nitrate? We saw a significant reduction in contrast-associated kidney injury.
Exactly. So we saw a significant reduction. So rates of contrast-induced nephropathy, which were significantly reduced, so essentially a third. So we saw rates from 30% down to just under 10% in the patients who were randomized to the potassium nitrate treatment, which we were obviously very happy to see that the primary endpoint was positive, showing a reduction in contrast-induced nephropathy with the therapy.
I'm honestly unaware of any other intervention that has the same impact on contrast-associated kidney injury.
Yeah, I mean, neither are we. The preclinical data we had did suggest that we may see up to a 60% reduction, and we were powered for a 60% reduction in contrast-induced nephropathy in the treatment group compared to the placebo, which is what the 640 patients allowed for us. But despite that, we did see a greater than 60% reduction, which from our perspective was great to see and justified both the power calculation and our hypothesis that there would be an improvement. And I think it's a very promising result to suggest that this may well be an effective treatment, and one that is definitely superior to other interventions that have previously failed.
That's great. And you also demonstrated a significant reduction in major adverse cardiac events went beyond the time of the procedure, even on follow-up. So any explanation for that?
Yes, and it's a really excellent question. I mean, we did see a significant reduction in both major adverse cardiac events and major adverse kidney events out to 12 months. So in the overall cohort, we had a MACE rate of just under 14% out to 12 months. That this was 9% in the inorganic nitrate group compared to just over 18% in the placebo group. So there was almost a 50% reduction in major adverse cardiac events, which were driven by predominantly a decrease or a reduction in non-fatal myocardial infarction and unscheduled revasc. But we also saw what we were quite surprised in, which was a reduction in all-cause mortality out to 12 months, which we were very surprised to see. However, I think there are multiple biological mechanisms that could explain why out to 12 months, which admittedly is a long time after a 5-day treatment, you might see a beneficial effect of inorganic nitrate. So we know that a contrast-associated acute kidney injury is itself prognostic, and there's multiple literature to suggest that this is associated with long-term adverse events. I think we also saw a reduction in procedural myocardial infarction. associated with the inorganic nitrate treatment. Again, based on the proposed biological mechanisms by which nitric oxide would prevent contrast-associated acute kidney injury, it makes sense that you would also reduce rates of procedural myocardial infarction if we have raised levels of nitric oxide, which we showed by elevating circulating levels of nitrate, which are in the publication. That should mean that it's anti-thrombotic, anti-inflammatory, and cytoprotective in all organs, not just the kidney, and therefore lower rates of procedural MI are logical. Now, obviously, we aren't powered for this, and arguably it's hypothesis generating. We do therefore plan further study to see whether in a larger MACE-powered study that these effects are translated. However, I do believe that based upon the signals we've seen in reduction in procedural MI, reduction in contrast-associated acute kidney injury, and also an improved renal function, there were greater rates of chronic kidney disease in the patients in the placebo group out to 3 months. So that we already were seeing a signal at 3 months of a long-term effect, and translating this into 12-month outcomes, again, I think biologically does make sense, even for the investigators, I admit it wasn't surprised that we saw this.
Okay, so we have a very simple solution, a couple of tablets that are taken before the procedure and for 5 hours after the procedure. They can cut a big proportion of contrast-associated kidney injury. They can prevent peri-procedural MI, and they can prevent MACE at 1 year. So are these tablets or pills available? Because I couldn't find them in the market.
No, and that currently would be the main limitation for somebody to be able to take what we believe is a very cost-effective, straightforward, safe, and simple dietary supplement, which in this trial has shown to do exactly what you've just said: reduce rates of contrast-associated kidney injury, reduce rates of procedural myocardial infarction, improve renal function at 3 months, and improve cardiac events out to 12 months. Now, we had the pills made for the study, obviously, because it was we needed a placebo and we needed them manufactured. Currently, the only way to buy the same dose of nitrate that we administered would be to take beetroot juice or a beetroot shot that are commercially available, and two shots of 70 mils or 140 mils would be the equivalent dosage of 12 millimole to be able to see these effects. We are planning a larger MACE-powered study, which we are already in the processes of setting up and securing funding for. And we would hope that if we can show in a larger study that when a phase 3 powered study, that these phase 2 results are translated, that would secure and push forward the process of having this drug manufactured and being readily available worldwide to be able to give to every patient undergoing angiography.
Okay, so from now on, I'll be prescribing 2 shots of beetroot for all my patients before going for angiography or for any contrast involving procedure. That's wonderful. It was great having you, Dr. Jones.
It's been a pleasure.
Pleasure is mine, and I hope we'll be seeing you again in the future.
No, thank you for your time. It's been a pleasure.
Thank you for being with us. We hope you enjoyed this episode of Cardio Buzz. If you did, give us a thumbs up and subscribe to the YouTube channel and to the podcast on Spotify, Google Podcasts, and on Apple Podcasts. And don't forget to check out our other episodes for more information on cardiovascular health. See you in the next episode.